on this. All right, let's talk about diabetes. Diabetes mellitus is an error in glucose metabolism. An error in glucose metabolism versus diabetes insipidus, which is dehydration. Okay, error in glucose metabolism versus diabetes insipidus, which is dehydration. There are two types. Type 1, which is insulin dependent, also called ketosis prone, or type 2, and you just have to put non in front of that. So it's non-insulin dependent and non-ketosis prone. The signs and symptoms of diabetes are the 3 Ps. I think you all know those. Polyuria, which is increased urination. Polydipsia, which is increased thirst. And polyphagia, which is hunger. Now, Mark says in every other context, polyphagia means frequent swallowing, because Mark is truly a connoisseur of language. I told you he sees patterns in words, and words are important to him. He's the most precise speaker of the English language I think I've ever personally talked to. I've heard other people speak as precisely as he does, but I don't know if in person I ever have. He uses words very, very carefully. He always speaks appropriate, or he always speaks correct English, like syntax and all that kind of stuff, right? He's very proper in the way he speaks because words are so important to him. So he puts that there. In every other context, polyphagia means frequent swallowing, because it drives him nuts when a word means more than one thing and then you have to figure out what it means. So I'm just letting you know, that's just kind of a funny story. All right, now I'm going to go off script. You ready? Now, what I would do if it were me is I would probably turn my book over and use the white page on the back. And I'm going to talk in 2 columns. So usually what I recommend is you put a line down the middle of the page, and we kind of do 2 columns. And on the left column is going to be type 1. On the right column is going to be type 2. All right, so let's compare and contrast these. And I do this because I want everybody to be on the same page. So if you know all this stuff, I do apologize. I just want to make sure everybody's on the same page with diabetes. There's a lot of people that just, whatever their educational level is, or the school they went to, maybe their school was fully online. I get a lot of this. My school was fully online. I had to teach myself everything. So I just want to make sure everybody's on the same page with this. So type 1. So the problem with type 1 is that there is no insulin. That's the problem. The pancreas is not making any insulin. Now, you have to have insulin in order for carbohydrates to be metabolized. Carbohydrates, I don't know if I'm spelling this right, but carbohydrates are metabolized inside the cell. And insulin is the key that unlocks the door of the cell. So if you don't have insulin, this carbohydrate cannot get into the cell to be metabolized. The word metabolized means broken down and used for energy. That's what metabolized means, broken down and used for energy. So if there's no insulin, then there's no carbohydrate metabolism going on. So the question is, what are we using for energy? Well, our backup is fat. Okay, so we can metabolize fat even in the absence of insulin. So we're going to metabolize fat. Now, fat can be metabolized efficiently, or it can be metabolized inefficiently. Now let's think about what that word means, efficiently. If I say, I want you to go study for the NCLEX and I want you to do it efficiently, you have to be efficient in your studying. What does that mean? Well, that means don't waste a bunch of time. Turn off all your alerts on your cell phone. Stop texting people. Turn off YouTube, right? You need to pay attention. Stop wasting time. Be efficient. So when I say fat is metabolized efficiently, that means low waste. If fat is metabolized inefficiently, that means there's high waste. Okay, so here's the question: what determines whether it's metabolized efficiently? So you don't have to know this. I'm just explaining it to you so you understand why it is, but then nobody's going to ask you this question on the NCLEX. When carbohydrates are metabolized, they release a substance called acetyl-CoA. And acetyl-CoA enters the fat metabolism cycle. And when acetyl-CoA enters the fat metabolism cycle, it allows fat to be metabolized efficiently. But when there's no carbohydrate metabolism going on, there's no acetyl-CoA being released, which means fats are not metabolized efficiently, they're metabolized inefficiently. So in the absence of carbohydrate metabolism, you have inefficient fat metabolism, which means you have high waste. Now, what is the waste product of fat metabolism? The waste product of fat metabolism is ketones. That's why type 1 diabetes is ketosis prone. And the only way to correct that, they don't have any insulin. They have no insulin. So the only way to correct that is give them insulin. That's why they're insulin dependent. They're ketosis prone and they're insulin dependent. Now, what are ketones? Are ketones acids, or are they acidic, alkalotic, or just neutral? All right, ketones are acidic. They're an acid. And if they're ketosis prone, are we prone to developing acidosis or alkalosis? When someone is type 1 diabetic, are they prone to acidosis or alkalosis? Well, they're clearly prone to acidosis. Now, is this a metabolic acidosis or is this a respiratory acidosis? I hope everybody said it's a metabolic acidosis. And it is. They're prone to metabolic acidosis. And you already know all about that because we learned about that. As the pH goes, so goes my patient, except for potassium. So I know that when they go into metabolic acidosis, they become lethargic. They can develop Kussmaul's, right? Remember, Kussmaul is Mark's Scottish neighbor, Colin Kussmaul. So prone to Kussmaul's, and as the pH goes, so goes my patient, except for potassium. So they're prone to hyperkalemia, right? So lethargy, fatigue, anorexia, hyperkalemia, Kussmaul's. Doesn't that sound like someone who's developing a metabolic acidosis? Now, because they're a diabetic and there's some other specific things associated with this, we actually give it a new name. Now, it still is a metabolic acidosis. I'm not saying it's not metabolic acidosis. It is. But we give it a name and we decide to call it diabetic ketoacidosis because it's specific to those ketones. So we call it diabetic ketoacidosis. So type 1 diabetics develop DKA. Now, is this person hyperglycemic or hypoglycemic? Someone who's in DKA, are they hyperglycemic or hypoglycemic? They are hyperglycemic, right? Hyperglycemic because the carbohydrates are not being metabolized. So sugars are carbohydrates, right? So it's building up. So when we check a serum glucose, serum is not in the cell. Serum is the fluid that's not in the cell, right? So if we check a serum glucose, it's going to be high. Now, how high is it going to be? Like, what's the number going to be? If they're hyperglycemic and they're developing a DKA, what kind of numbers are we looking at? Well, we're looking at probably greater than 400, maybe up to, say, 700, like 400 to 700, maybe somewhere in there, right? They are hyperglycemic. Now, how do we treat DKA? How do we treat it? Well, what is the underlying problem with DKA? The underlying problem with DKA is no insulin. So how are we going to treat it? Well, we have to give them insulin. And the fastest route to give insulin is IV. And the type of insulin that's given IV is regular. So we give IV regular insulin. Now, they're also dehydrated because of the polyuria. And they do develop anorexia because of the DKA. And as the pH goes, so goes my patient. But they still become dehydrated. So we do rehydrate. But it's like, maybe we'll run in their IV fluids at, say, 150 to 200 mils an hour. Because they are dehydrated. But the primary thing, if we don't give them regular insulin, they're going to die. Like, I can rehydrate them all I want to, but if I don't give them regular insulin, they're going to die. They don't have any insulin. Or if, I should say, if I don't give them any insulin. All right, so we have to give them insulin. All right, so let's talk about type 2 diabetes. Okay, what is the problem? What is the underlying problem? The underlying problem is not no insulin. They have insulin. The underlying problem is insulin resistance. Now, insulin resistance does not mean there's necessarily a problem with the insulin. It means there's a problem with the cell. You know, if you get a new key, you lost your key, maybe you actually have a house key, like we have the code that you log in, so we don't even have a house key, we have a code. But if you still have a house that has a key, maybe if it's an older house and the lock is sort of old and you lose your key, so you got to get a new key. So you get a new key and you're trying to fit it in that lock, and that lock is a little resistant to it. Have you ever noticed that? You kind of have to jiggle, jiggle, jiggle. Well, that's sort of what insulin resistance is like. So insulin resistance, the lock is resistant to the key. The key is okay, but the lock is resistant to it. Now, most of the time, it can get the cell door open, most of the time, but not all the time. Not all the time. So, there's some issues with that. Now, do you know, this is kind of just a general question. Do you know what causes the number one cause of insulin resistance? What's the number one cause of changing that lock? Do you know? It's obesity. Obesity is the number one cause of that resistance to insulin at the cellular level. Okay, obesity is number one cause. All right, so they have insulin resistance. So the question is there any carbohydrate metabolism going on? Yes or no? Is there any carbohydrate metabolism? Yes or no? Yes, it's less, but they still got it going on, right? They still got carbohydrate metabolism going on. So is fat metabolism efficient or inefficient? Well, if they have carbohydrate metabolism going on, then they do have acetyl-CoA entering the fat metabolism cycle, which means the fat is being metabolized efficiently, which means they are non-ketosis prone and non-insulin dependent. They're not insulin dependent. They have insulin. Okay, so that is why they're non-ketosis prone and non-insulin dependent. They're not developing high ketones. Now, do not say to me, I took care of somebody one time who was a type 2 diabetic who was releasing ketones. I believe you. I do. But that is an outlier, not the general principle. And what did I tell you about the NCLEX? I said the NCLEX is testing what? General principles, not exceptions, not outliers. So do not answer the NCLEX questions based on the outliers or the exceptions. That's why you can't say, well, maybe this could happen, because anything might happen or could happen. Anything might happen or could happen. But that's not how they're testing you. They're testing you on general principles. The norm, even if the norm is 51%, they're still testing you on the norm. Okay? So if they have insulin resistance, now normally normal blood sugar in a non-diabetic person is anywhere between like 70 and 110, somewhere in there. Okay, that's normal blood sugar. So for a person with type 2 diabetes, what kind of blood sugars are we looking at? Because they have insulin resistance, but they're not going to go into DKA. So what kind of blood sugars are we looking at? Well, we're not looking at 400 or 500. We're thinking, well, maybe 150 to 200, somewhere in there, right? This is a type 2 diabetic. And they don't really feel that sick. Now, they do have the symptoms of diabetes, which are the 3 Ps, so polyuria, polydipsia, and polyphagia. So they are experiencing that, but they're probably making excuses. They're like, oh, I'm just getting old, so I have to go to the bathroom more. Oh, I'm just thirsty a lot. I'm getting, I've eaten a lot more. I'm kind of fat anyway. So, I've always liked my food. So they're making excuses for it, and they're not really thinking they're diabetic until maybe they go for a screening. Maybe they have a health fair at where they work, or maybe they go in for their annual exam and somebody assesses them and they go, oh, you're a type 2 diabetic. And they're like, oh, I didn't know that. Okay. So those are the kind of blood sugars that you're looking at when a patient is, healthy and doing okay. I mean, healthy and they're not acutely ill. They have diabetes, but they're not acutely ill. That's probably where they're running, even without treatment. But let's say we have an older adult, like an 80-year-old lady who just had a stroke. She just had a stroke. She ends up in a nursing home. She's a type 2 diabetic, but she really isn't able to drink like she used to. And she's just not, she's just not able to take care of herself. She doesn't walk anymore. But she still is experiencing polyuria. She's still experiencing polyuria, but she's had this stroke and she's not getting the care like she used to. And so she ends up becoming dehydrated. So let's say this is our 80-year-old lady, and this is how much fluid she normally has. And she has this many glucose molecules. Okay, that's how many glucose molecules she has in that much fluid. And that's a blood sugar of 150 when we test it. But now she's had a stroke and she's in a nursing home, so now she's becoming dehydrated. But she still has the same number of glucose molecules in her blood, but now it's really concentrated. Really concentrated. If we check her blood sugar, do you know what her blood sugar is probably going to be? Now her blood sugar is going to be probably 1,000 to 1,500. Well, how in the world did it get that high and we didn't know it? Because she's non-ketosis prone. The reason your DKA patients end up in the ED is because their pH drops. And when their pH drops, they lose consciousness and they have all these other things that go on. You go, oh no, they found I think their blood sugar's whatever. And they take, they call it squad and they get them in there. But the reason they're in there is not, the reason they have their symptoms is not because their blood sugar is 500. It's because their pH is 7.15. But they're not ketosis prone. So you don't see any of that. You don't see any of that acidosis. You don't know they're like that until their blood sugar gets up to 1,200 and all of a sudden they go into a coma. But what is the problem? Because the problem isn't ketosis, the problem is dehydration. And we call that hyperosmolar. Because they're really dehydrated, hyper concentrated, and they're extremely hyperglycemic. So not only hyperosmolar, they're hyperglycemic, but they're non-ketotic, and they end up in a coma. So do you know what we call this? We call this HHNK. Sometimes we call it HHS, hyperosmolar hyperglycemic syndrome. Sometimes they leave off the non-ketotic, but this is where they end up. Now, what is the underlying problem? Now, I know it's insulin resistance, but what's really the underlying acute problem? The underlying acute problem is dehydration. So what is the treatment, number one treatment for this? Rehydrate. Will we give them insulin? Of course, we'll give them some insulin because their blood sugar is 1,500, but we're not gonna give them insulin for very long because they're probably going to give them 4 liters of fluids in the ED, and by the time they make it up to the unit, the ICU, they're coming to the ICU. They've given them 4 or 5 liters of fluid in the unit or in the ED, and by the time they get up to the unit, their blood sugar is probably down to 600. And so, yeah, we're going to give them insulin, but not for very long because their blood sugar is going to come down really quick once we start hydrating them. All right, that's all I have to say off script. Now we're going to go back Now we're going to go back to the book. So going back to the book, I'm going to start filling in some blanks. We're going to fill them in kind of quickly. Okay. All right, so let's talk about treatment. Type 1 treatment, page 25, type 1 treatment. The D stands for diet. Okay, the D stands for diet, insulin, and exercise. Now, this is not the order. Okay, this isn't the order. What is the, out of these, if you have to say, what's number one for type 1 diabetic out of these three, what's number one? Well, obviously insulin is. Well, what's number two? Okay, what's number two actually is exercise, because exercise does the same thing as insulin. So you can have, if you exercise, even if there's no insulin, it can get your blood sugar down. So if someone's insulin dependent, wouldn't we want them to do something that acts just like insulin? Yeah, that's exercise. Okay, so diet, insulin, and exercise, these are the treatments for type 1. Then type 2, we have diet, oral, hypoglycemics, and activity. Now, activity means the same as exercise, means the same thing. It's just we needed to make it fit in this, okay? So what is number one for type 2 diabetics? Out of these three things, what's number one? Number one is diet. Don't say oral hypoglycemics. I know everybody you take care of is on an oral hypoglycemic, but the question is, what is the best way to control blood sugar in type 2 diabetes? The best way to control blood sugar is diet and exercise, y'all. And I know you all know that. Diet and exercise is the best way to manage type 2 diabetes. I know you all know that. The only reason you would pick oral hypoglycemics is because everybody you know takes one. But the NCLEX is a perfect world. And if you teach a type 2 diabetic to manage their diet and activity, they're going to do it. All right, page 26. Let's talk more about diet. Diet is all about calorie control. Calorie control. We need to keep, there's only so much workable insulin. Now, the insulin's fine, but so many cells are accepting it, right? So if we know only so many carbohydrates are going to get into the cell, we have to limit the number of carbohydrates that they take in. And if we can limit the number of carbohydrates they take in, then we can manage their blood sugar. It's simple as that. Now, there's an additional thing that often helps: need 6 small meals a day. 6 small meals a day is better than 3 large meals a day. So it's calorie control plus 6 small meals a day. That's what we recommend to people who are type 2 diabetics. Calorie control plus 6 small meals a day. Let's talk about insulin. Insulin acts to lower blood sugar. Insulin acts to lower blood sugar. The different types of insulin, I like tables, so we're going to do this table here: regular insulin and NPH. Okay, regular insulin, just so you know, is clear. NPH is cloudy. Regular insulin is called fast acting. NPH is called intermediate acting. All right, the onset of regular insulin is 1 hour. The peak is 2 hours, and the duration is 4 hours. For NPH, the onset is 6 hours. The peak is 8 to 10 hours, and the duration is 12 hours. Now, do you see the pattern there? 1, 2, 4, 6, 8, 10, 12. I hope you see the pattern there. Okay. Somebody said, what about type 1 diet? What about type 1 diet? They're probably not going to ask you much about that because anymore what they say is you measure the number of carbohydrates you take in and then you administer the insulin according to your carbohydrate counting. So they're probably not going to ask you much about type 1 diet. They're going to ask you more about type 2 diet. Now, let me ask you this question. When is the patient most likely to experience hypoglycemia? Are they most likely to experience hypoglycemia at the onset, the peak, or the duration? Which one? Onset, peak, or duration? When are they most likely to experience hypoglycemia? The answer is at the peak. Okay, they're most likely to experience it at the peak. So if they say you administered the regular insulin at 0800, when are they most likely to experience hypoglycemia? Your answer is 10 o'clock. I don't care when they ate their dinner. It's strictly based on when they took the insulin. That's how you determine it, based on when is the peak. Now, if they say you give them their NPH at 9 a.m., when are they most likely to experience hypoglycemia? Well, 9 plus 8, 17. So between 1700, 9 plus 10 is 19. So between 1700 and 1900 is when they're most likely to experience hypoglycemia. That's between 5 and 7 p.m. All right, let's talk about Lispro. Lispro is rapid acting. Lispro, the onset is 15 minutes. The peak is 30 minutes. And the duration is 2 hours. So if I were to say, when should you give Lispro? 30 minutes before the meal, with the meal, or mealtime doesn't matter? When do you give Lispro? 30 minutes before the meal, with the meal, or mealtime doesn't matter? The answer is with the meal. Always with the meal. Don't give it 30 minutes before the meal. You give it 30 minutes before the meal, it's peaking before they even eat. That's bad. Now, regular insulin, because the onset is 1 hour and the peak is 2 hours, regular insulin can be given 30 minutes before the meal. Regular insulin can be given and should be given 30 minutes before the meal. All right, glargine. And I don't know if you can tell in your book, but they've actually underlined the large. Large, so remember it's long acting, long acting. And the interesting thing about this is there is no peak. It doesn't say that there, I'm telling you, it has no peak. And the duration is 12 to 24 hours. So if they're, glargine is the same as Lantus. There's a couple other names for it. I'm blanking on it right now. Anyway, there's no peak. Now, if there's no peak, here's the implication. Hypoglycemia is not a risk. Now, you can say, I don't believe that. Okay, you don't have to believe it in real life, but on the test, you have to believe it. Because if hypoglycemia is a risk at the peak and there's no peak, then hypoglycemia is not a risk. Therefore, you can give it when the patient is NPO. You can give it at bedtime. You can give it at bedtime with no snack, and you can give it when the patient is NPO. That's the implication of that. And it's given once or twice a day. Once or twice a day, never more often than that. Never more often than that. Once or twice a day. Someone said Lispro duration is 3 hours. It's fine. If you want to say Lispro duration is 3 hours, that may have been what Pete or Trevor might have told you. I don't know if that's what they tell you or not, but I think they said 2 to 3 hours. And so I texted Mark, Trevor, and Pete, and I said, hey, I'm saying 2 hours. What's the deal? And Mark said, it doesn't matter because nobody cares what the duration is. No, literally nobody cares what the duration is. You will not be tested on the duration. You'll be tested on the onset and the peak, and nobody cares about the duration. So I still say it's 2 hours, but it's 2 to 3 hours, fine. All right, let's keep going. Insulin. Let me make this so you can see it in case anybody wants to like take a picture of it or something real quick. Okay, if you don't want to take a picture because then I'm gonna move on. What time is glargine given? Twice a day. It doesn't matter what time it's given, as long as they give it when it's ordered, because there's no peak. But insulin usually is given in the morning and at bedtime. So typically 9 a.m. and 9 p.m. That's typically when it's given. But it's not wrong to change the times. You can do 8 and 8, whatever. Okay. I will say some of you, I'm sure it's not all of you, some of you are focusing on minutia. Minutia. Don't focus on minutia. They're not testing minutia. If you think they're testing minutia, it's because you've spent too much time studying the rationale in UWorld. Rationale in UWorld focuses on the minutia. That's why I hate the rationale in UWorld, because it focuses on the minutia and it is of absolutely no consequence. Stop focusing on minutia. When I say that, I mean like, what time is glargine given? That's minutia that you don't need to know. You have to understand concepts. For example, you do need to know 30 minutes is the peak time for Lispro, but that's not the concept that you need to know. The concept you need to know is it has to be given with the meal. That's the concept. Okay? So that's what I'm saying. I want you to think conceptually and not think so much about those specifics. For people who don't speak English, minutia. You don't know what minutia is. Okay, minutia. Here's minutia. That's how you spell it. And it's small, specific, usually unnecessary details. That's what minutia are. Small, specific, usually unnecessary details. Camera. Okay, let's keep going. Yes, Rebecca, and we'll get to that. All right, let's keep going. All right, check the expiration date. Check the expiration date. So here's what that means. So you look at the insulin bottle, and usually the expiration date is pretty far away. So let's see, today's 1/21/23. So let's say you check the expiration date and it says the expiration date is 3/20/24. Okay, that's over a year away, right? That's why you keep it in the fridge when it's not opened. Keep it in the fridge when it's not open, because look at that. It's got to be good for another year and 3 months, 2 months, right? It's got to be good for a long time. So I'm keeping it in the fridge. But once I pop the top, once I open it, I'm going to cross off this date and I'm going to rewrite the date. Today is 1/21. So I'm going to write 2/21/23. Now this is the new expiration date, and I'm going to write it for 30 days. Now, do not get focused on the minutia, y'all. Don't say, well, but January has 31 days in it. So if I were to actually do it for 30 days, it would have to be February 20th. Or don't say, but I was taught 28 days. That right there is minutia. They are not going to make you decide between whether you should write it for 12, 221, 220, or 219. Those are not going to be your options. Your options are going to be like 15 days, 30 days, 90 days, 3 months. Those are going to be your options. Okay? And you go, well, yeah, 30 days. All right, now refrigerate when unopened, because it has to be good for a really long time. But once you open it, you can keep it in the bedside table if you want to. Don't keep it on the windowsill. Cannot handle extreme temperatures. If it freezes, it's destroyed. Pitch it. If it sits in the sun, it's destroyed. Pitch it. Throw it away and get a new bottle. Cannot handle extreme temperatures. No freezing, no sitting in the sun. You can put it, but if it's opened and it's only got to be good for 30 days, now you can keep it at your bedside table. But if it's not opened, it has to be in the fridge. Now listen, it is never wrong to refrigerate insulin. Never. If somebody says, do I have to refrigerate my insulin after I open it? You say, no, you don't have to. If they say, can I refrigerate it after I open it? You go, of course you can. Yeah, that's up to you. It doesn't matter. You don't have to. You have to refrigerate it before it's opened. You don't have to refrigerate it after, but you can. No big deal. It's fine. Whatever makes you feel most comfortable. All right, let's talk about exercise. Exercise potentiates insulin. That means it does the same thing as. If more exercise, less insulin is needed. If less exercise, more insulin is needed. Priscilla, I know you keep asking questions. I can't interrupt my lecture constantly to answer the questions. The only two that can be mixed together are regular and NPH, and that is coming up. That is coming up in another lecture. Okay, it's not in this lecture, it's coming up. So we'll get there. All right, let's talk about sick days. Sick days is really, really important. You guys, you're killing me on the minutia here. Is 30 days for all types of insulin? Yes. So it's the same. Don't worry about it. It's the same for all types of insulin. All right, let's talk about sick days. I'm not going to look at the Q&A anymore, by the way, till we get done with this lecture, because it's just slowing me up. Okay, let's talk about sick days. Take insulin as ordered. Now, I'm teaching you concepts here. Do not memorize the words, memorize the concept. Okay, and I'll explain to you what I mean by that. Take sips of water and stay active. Okay, these are concepts. These are not words for you to memorize. You're not going to see, if they say, what's important for sick days? They're not going to say, take the insulin as ordered. That's not what they're going to say. So here's the thing, when someone gets ill, they get sick, they release stress hormones. Stress hormones increase blood sugar, sometimes a lot. You ever notice that your sick patient's blood sugar in the hospital is a lot higher? Like they'll say, my blood sugar is never this high. I know, you're releasing a bunch of stress hormones, it's jacking your blood sugar up. So that's the concept. When they're sick, they release stress hormones and it's jacking their blood sugar up. Okay, That means that even if they're not eating very much, they take their insulin as ordered. If they're ordered glargine and there's no blood sugar checks associated with glargine, then they just take it even if they're not eating very much. If they're scheduled to take sliding scale insulin according to their blood sugar, keep doing it. I don't care if you're not eating. If you're not eating, then just check your blood sugar every 4 to 6 hours. But you got to keep taking it just as ordered. Now, it may say take your insulin according to blood sugar. Fine. That's fine too, but you've got to keep taking it. What they cannot do is say, well, I'm not eating much. I've been throwing up a lot. I'm just not going to take my insulin. That is plain wrong. No, no, no. They have to take their insulin because they can end up in DKA if they don't. Because when they're sick and they're releasing all these stress hormones, whether or not they're eating or not, their blood sugar can get very high. Now, take sips of water. What happens when someone gets dehydrated? I spent all that time talking to you about that. Remember, I did that off script teaching you about diabetes because I wanted everybody to be on the same page. What happens when people get dehydrated? What happens to their blood sugar? It goes through the roof, y'all. It goes through the roof. They cannot let themselves get dehydrated. So is NPO a good option? Absolutely not. They have to keep drinking, but I'm nauseated. Take sips of water as much as you can. You've got to stay hydrated and stay active. Well, if exercise does the same thing as insulin and all you're doing is laying around in bed all the time, that's not good for a diabetic. Stay as active as possible. You don't have to run a marathon. You don't have to walk around the house, but bed rest is probably not your best option. Now I'm just going to give you one more thing before we turn the page. I've seen questions like this, and it's almost like a trick question, but it's not supposed to be, but they're really testing whether you know this. They say your patient is admitted with an exacerbation of COPD. They're also a type 2 diabetic. Which of the following would you expect for their plan of care? Select all that apply. Type 2 diabetic, admitted with exacerbation of COPD. Which would you expect in their plan of care? Select all that apply. Bed rest. Are you going to pick that one? Is that what you expect for this patient? Well, they're in with an exacerbation of their COPD. They sure are, but they're also a type 2 diabetic. So are you going to put them on bed rest? No, you are not. This is not just when they have no other comorbidities. This is talking about when they're diabetic. You have to take that into consideration. I don't care that it's exacerbation of their COPD. Now, if they're like, I'm just too exhausted, I can't walk, fine. But we're not putting them on bed rest. That's not the order. They're not going to have to stay on bed rest. How about this? Accu-Chek's AC&HS. You go, well, they're type 2 diabetic. They're not taking insulin. Why would I check their blood sugar before meals and at bedtime? Because they're sick, y'all. Think. This is a concept. Now, I'm being hard on you. I know. I'm being hard on you because I want you to understand this. I want you to hear me. I don't want your mind drifting off. Okay, we're sitting here. It's been almost 4 hours. And you're starting to think about dinner and your mind's starting to drift off. And I'm trying to keep your attention here. Think about it. Does it make sense that we would want to know what their blood sugar is if they're sick? Yes, it would. You understand that? So you have to test conceptually. There's so many times, and this is why it's good to watch the SATA videos. I have 9 SATA videos on YouTube, and I spend a lot of time talking about this on there, talking about thinking conceptually. No, it's not the clinic review on there, but what I'm doing is I'm teaching you how to think like a nurse, right? And I say, think conceptually. Don't get bogged down in the details. Think conceptually. Does this make sense? Why would I want to have them do Accu-Chek's AC&S, even though they're a type 2 diabetic? And if you understand the pathology, okay, that's why you have to understand that. Now I say, don't read all the rationale in UWorld. And yeah, sure, rationale in UWorld will tell you all that stuff. But it's still too much. It's too much. It's just too much. You can't do it for every question. So that's why I say you have to self-evaluate. What do I know? What do I not know? And if you're like, I don't know why I would do Accu-Chek's AC&HS, then you can text me. But remember, you're only allowed to text me 3 times a day because I'm not your personal Wikipedia page. Okay? You got it? Everybody got it? All right. Complications of diabetes mellitus. All right. I want you to think Balbier, you just asked me a question. I want you to think about whether that is within the nurse's scope of practice. Think about that. Is this question within the nurse's scope of practice? Is this really a question that we as nurses are expected to know the answer to? So I want you to think about that, and then I want you to type in again, what do you think, okay? I'm not going to get rid of your question. I want you to respond to me via Q&A and say, well, do I really think this is something that was in our scope of practice that I need to know the answer to? All right, page 27, complications of diabetes. They test on this a lot. Low blood glucose and type 1 diabetes. Insulin shock or hypoglycemic reaction causes. Okay, complications of type 1 diabetes. Not enough food, too much insulin, too much exercise. The danger is brain damage. This is why hypoglycemia is worse than hyperglycemia. It can cause brain damage. The signs and symptoms are caused by cerebral impairment and vasomotor collapse. All right, cerebral impairment. If I say they're driving while impaired, what does that usually mean? Usually means they're drunk, right? So when you see the word impairment, I want you to think drunk, because cerebral impairment, they look like they're drunk. How does a drunk person look? Well, they're stumbling around, they're slurring their words, they have emotional lability, they have slowed reaction times, their processing is off, right? That's drunk. Vasomotor collapse. Vasomotor collapse is shock. So how does a person who's hypoglycemic look? They look like they're drunk and in shock. And the reason that we teach it this way is because we don't want you to memorize a list. There is no definitive list anywhere about what hypoglycemia looks like. Listen, there is no definitive list anywhere that says what hypoglycemia looks like. The reason they have symptoms is because of cerebral impairment and vasomotor collapse. So if you get a question, like it's a SATA question, and it says, which of the following would you expect for a patient who's hypoglycemic, or what would you watch for hypoglycemia? Don't say, oh, what list did I memorize? That wasn't on the list. I can't pick it. I didn't memorize that. That's why we don't want you to do it. You have to test conceptually, particularly SATA questions. SATA questions are all about concepts. Do I understand what's going on here? And if I do, then I'm going to pick the answers that show I know what's going on here. All right. And by the way, in the past, I have spent some time talking about shock, and it's just too time consuming. I just can't do it. I can't get through everything if I do that, which is what motivated me to put a YouTube video called Pressure and Perfusion. Okay, on YouTube, we have I have a video called Pressure and Perfusion. And if you do not understand shock, or you don't understand pressure changes, you need to watch it, because it is a fundamental principle. And if you don't understand it, you have to understand it. And I have found it may be better now since COVID, but during COVID, people just were not getting the education that they used to get. And they were looking at me like, I've never heard of that. So if you don't know it, you got to watch that video. Okay, don't watch it if you know it. Don't worry about it if you know it. It's fine. All right, let's talk about treatment for low blood sugar. Remember 15 times 3. So if they're hypoglycemic, which by the way is less than 60, it's a blood sugar less than 60, you give 15 grams of carbohydrates. You wait 15 minutes and you recheck their blood sugar. If it's still low, you give them 15 more grams, wait 15 minutes, recheck their blood sugar. If it's still low, you give them 15 grams of carbohydrates, wait 15 minutes. If it's still low, you call the healthcare provider. 15 times 3. This seems very simple, but don't mess it up. If they say give them 30 milligrams of 30 grams of carbohydrates, So no, I'm not giving them 30 grams of carbohydrates. I'm giving 15. What if it says give them 20 grams of carbohydrates and recheck their blood sugar in 30 minutes? No, I don't give them 20 grams of carbohydrates and recheck in 30 minutes. I give them 15 grams of carbohydrates and recheck in 15 minutes. Okay? If it says, if it's still low after the first time, call the healthcare provider. Say, no, I'm not going to call the healthcare provider until after the third time. Okay? Am I keeping you awake? We're getting there. We're getting there, I promise. If unconscious, nothing by mouth. NPO, don't give them anything by mouth. That includes under their tongue, y'all. The mouth is the mouth is the mouth. So don't give them anything by mouth. You have to give it to an IM or IV. Oh, I don't know if I get through the rest in 4 minutes. We may be 5 minutes over for lunch, okay? So I do want to finish this lecture before we go for lunch. High blood sugar and type 1 diabetes. This is DKA, which we've talked about already. Causes too much food, not enough insulin, not enough exercise. The number one cause is acute viral upper respiratory infection within the last week. You know how many diabetics get sick, don't take their insulin, don't stay hydrated, and they end up in the hospital the next day with DKA or HHS. Do you know how many do? A lot. You have to teach sick care. That's why teaching sick care is so important. So many people get sick. Diabetics get sick with something else, right? Something else. And they end up in the hospital in DKA the next week. Very common. All right, page 28. Let's talk about signs and symptoms of DKA. All right, signs and symptoms of DKA. You don't have to memorize these. You don't have to memorize these. D is dehydration. I need to open up my other book to make sure I don't miss any of the words. I don't think I will. Let me make sure. All right. Yeah, okay. Dehydration, and the K is ketosis, Kussmaul's, and hyperkalemia. And you know all this. Because if you know, as the pH goes, so goes my patient, except for potassium, then you know all this. A is acidosis, acetone breath, which is specific to the ketosis, by the way, and anorexia, which is related to the low pH. As the pH goes, so goes my patient, except for potassium. So it's a down symptom. Anorexia is a down symptom. The treatment for DKA, number one, is IV regular insulin. Number two is fluids, high flow. Now, make sure if you get a question like this that you pay attention to if it's asking you what's best or what's first. Sometimes best and first is the same answer. Sometimes it's not. Do you think you hang the saline first, or do you think you hang the IV regular insulin first? You hang the saline first. We always hang the saline first, always. And then we piggyback the insulin into that, or we pig it, we put it into the second IV or whatever, but we always hang the saline first. So you hang the saline first, but if it says what's best, you say, oh, IV regular insulin, right? So pay attention. Does it say first or does it say best? I know I'm zooming. I'm zooming now. Okay, let's keep going. High blood sugar and type 2 diabetes, called HHNK or HHNC, hyperosmolar hyperglycemic non-ketotic coma. This is dehydration. Signs and symptoms are like the signs and symptoms of dehydration. And the treatment is to rehydrate. Whoops. Oh my goodness. What's going on? Okay, long-term complications of diabetes are related to two things: peripheral neuropathy and poor tissue perfusion. Again, concepts. We're not just giving you a list of the complications of diabetes. Because any disease that is peripheral neuropathy is a potential complication of diabetes. And any disease that is associated with poor tissue perfusion is a potential complication of diabetes. Like heart attack, that's poor tissue perfusion. Stroke, poor tissue perfusion. Kidney failure, poor tissue perfusion. Peripheral arterial disease, poor tissue perfusion. Right? So don't memorize a list. If it says which of the following are potential complications of diabetes, you go, well, is that a tissue perfusion issue? Is that a neuropathy issue? If it is, I'm going to pick it. Okay, do not try to memorize some definitive list somewhere. Nobody can remember lists. I can't remember lists. I don't want to remember lists. I want to remember concepts. And particularly SATA questions are testing your understanding of concepts. Which lab test is the best indicator of long-term blood glucose control compliance? It's the glycosylated hemoglobin, which is the hemoglobin A1C. Hemoglobin A1C. It gives you the indication of 3 months. 3 months, the average of 3 months. And healthy, normal, healthy, non-diabetic. You want it to be less than 6. But in a healthy diabetic, you want it to be less than 7.